Good afternoon. Welcome to Medical Grand Rounds. I'm Bob Wachter, Chair of the Department of Medicine. Usual ground rules for Grand Rounds today. Closed captioning is available. Q&A, please type them into the box, and Lakshmi will be monitoring them. We'll try to get to as many as we can. CME is available if you're interested. Stay on at the end, and there will be instructions about how to do that. And this will get posted on YouTube probably the next day or so. A quick programming note, we've been virtual only for the last 6 months or so. Next week will be hybrid because we have a visiting professor, Dr. Udebe Essien from UCLA, coincidentally sponsored by the Center for Vulnerable Populations, which you'll hear about more in a bit, and the Department of Medicine, who's speaking about pharmacoequity. That will be in room N217. That's right by Ladle and Leaf in the nursing school. And also virtual. And then as we get into next year, we're going to think about hybrid, and we'll see what happens with COVID and the triple-demic as to in terms of whether we go virtual only or go hybrid. We will let you know. But this week, we're incredibly excited to have as our speaker Dr. Margot Kushel. Margot, as most of you know, is Professor of Medicine and Division Chief and Director of the UCSF Center for Vulnerable Populations. She also directs the UCSF Benioff Homelessness and Housing Initiative. Margot received her bachelor's degree from Harvard, MD from Yale, and then came to UCSF for residency, chief residency, and fellowship in internal medicine. She is a practicing general internist at the county, in addition to her research, which focuses on the causes and consequences of homelessness and housing instability. She's principal investigator of a major NIH study on homelessness, examining the causes and consequences of homelessness in older adults. Also the principal investigator of the California statewide study of people experiencing homelessness. She has made many media appearances and many appearances before various government and private bodies, as all of us are trying to address the challenges of homelessness, something we see quite tragically pretty much every day. So we're thrilled to have Margot as part of our team and look forward to hearing her thoughts about aging and homelessness, causes, consequences, and solutions. And the format today will be a lecture, and we'll make sure we have time at the end for question and answer and discussion. Margot, welcome.
Thank you so much for that introduction, and thank you for having me. Just going to do the most stressful part of the presentation. Seeing the slides okay?
Perfect.
Terrific. So thanks for joining. I'll be talking about aging and homeless populations, causes, consequences, and solutions. I'm still on Twitter, so if you're interested in following, follow along there. Just some disclosures. This project is funded by the National Institute on Aging and Mark and Lynn Benioff Foundation. I have no conflicts. I'll start with just the land acknowledgement. We would like to acknowledge the Ramatash Ohlone people, who are the traditional custodians of this land. We pay our respects to the Ramatash Ohlone elders, past, present, and future, who call this place the land that UCSF sits upon, their home. We're proud to continue their tradition of coming together and growing as a community. We thank the Ramatash Ohlone community for their stewardship and support, and we look forward to strengthening our ties as we continue our relationship of mutual respect and understanding. This is one of our study participants, and I have his face on mind as I think about this issue. This sounds like it could be the lyrics to some Broadway musical, 580, 466, but it is a cited number of the people experiencing homelessness on a single night in the United States. This number is imperfect, it's likely an underestimate, and it's only a point in time. The number of people experiencing homelessness is 2 to 3 times this over the course of the year. And in this talk, we're going to talk about how we got there and how we get out of it. When we think about the question, why are there so many people homeless? I encourage you to think about it in 2 different ways, because the answers are different and these often get conflated. I think the question that people most often have on mind is, why are there so many people in this region, in San Francisco, in California, that are experiencing homelessness? But sometimes people answer a different question without realizing, where they're asking, why is this particular person homeless? And this is a framework put out by Mary Beth Shin and Jill Kaduri in their fabulous book, In the Midst of Plenty. They This is a framework to answer those questions, put out by Marty Bird and others in a book that came out in the late 1990s that talks about homelessness as an interaction between structural factors, things like the availability of affordable housing, stagnated wages, income inequality, racism, and individual vulnerabilities, things that people often think about when they think about homelessness, mental health disability, substance use disorders, adverse childhood experiences. And then the presence or absence of a safety net. Is there income support, safety net healthcare, subsidized housing? It turns out the less favorable the structural factors and availability of the safety net is, the fewer individual vulnerabilities one needs to become homeless. If you have the opportunity to visit Northern Europe, where they have a relatively flat income structure, great safety net, and the like, you will still see some people who are homeless, many fewer than we have here. Those people are much likely to be people with severe individual vulnerabilities. To be homeless, however, in 2022, in the United States, you don't actually need to have very many individual vulnerabilities to wind up homeless. This is a recent fabulous book, Homelessness is a Housing Problem, put out by Greg Colburn and Clayton Aldern, which talks about the drivers versus the precipitants of homelessness. They describe the drivers as the systemic factors that create overall homelessness rates and explain the difference in homelessness between communities. They really call out the lack of affordable housing, income inequality, and I would add structural racism. And then they distinguish that from the precipitants, what they call the precipitants, or the individual risk factors that increase the chance that any individual becomes homeless. These are things like substance use disorders and mental health problems, which absolutely increase a person's chance of becoming homeless. They put forward this analogy. Actually, when I talked to them as they were writing the book, I recommended it. They told me later that just about everyone they talked to recommended it. They actually refined it. And I think it's really helpful to really understand these concepts. Think about a game of musical chairs. Maybe you've played it with your kids at a birthday party, 10 kids, 10 chairs, they play the music. The adult pulls away a chair, the music stops, and the kids scramble for the 9 remaining chairs. If you were playing musical chairs and you had a kid who sprained his ankle the night before and was just learning to use their crutches, when you pull away the chairs, I could almost guarantee you that that would be the kid who is most likely to be standing. If you ask the question, why is this kid standing? Well, it's because he was on crutches and he couldn't get to the chair. But if you ask actually the more relevant question, why is there a kid standing? There's a kid standing because you only have 9 chairs. If you had had 10 chairs, the kid on crutches would have found his way to a seat. And if you had no kid on crutches, someone still would have been standing. The reason we have so much homelessness is the rent is just too high. There is just not enough housing. We basically have fewer than 9 chairs for 10 people. And that's why we have homelessness. So if you wonder, well, why is homelessness so bad in California? Is it the warm weather? It is not. Is it is it some other reason? It is not. It is because of this. We are the second worst state in the nation on this key indicator of housing. In the United States today, we have 36 units of housing that are both affordable and available for every 100 extremely low-income household. Extremely low-income household is any household that makes less than 30% of the median income of the area in which they live. The median income in San Francisco is much higher than a small town in Tennessee. They each have their own median income. Any household who makes less than 30% of that is extremely low income. In California, we have a whopping 23 units of housing, both available and affordable for every 100 extremely low-income household. Available and affordable means that that household can pay for it, spending less than 30% of their income on the rent. If you spend more than 30% of your income on the rent and you're very poor, you've got nothing left over for food, healthcare, et cetera, and you're at high risk of homelessness. We are simply not going to solve this problem until we shrink that gap. We are short 1 million units of housing, of extremely low-income housing in our state. And in some ways, it's a miracle that we only have 170,000 people experiencing homelessness every night. There is no honest way to have a discussion about homelessness in this country without calling out the obvious, that this is an issue of racial injustice and racism. I want to remind you all that in the United States, home ownership has been the primary means of intergenerational wealth building between families. And that until relatively recently in our collective history, there was legalized discrimination in home ownership. This was immoral, unethical, racist, but legal until the fair housing laws were passed in the late 1960s. This worked through various processes, including racial covenants, so that areas could basically say white owners would have in their mortgage or in their ownership documents that they couldn't sell to anyone who was non-white. In that neighborhood, keeping neighborhoods segregated. And then the banks, the federally backed banks, got into the act and they redlined the areas, meaning that they wouldn't give you a mortgage if you lived in an area that only, that Black or brown people had available to them. It's worth noting that we still basically live in these formally redlined areas. We can trace the racial dynamics of the community based on those formal maps. That is not just because those maps existed in the past, but because it is no longer legal, but the same sort of phenomenon still occurs. And because Black and brown Americans were completely left out of the post-World War II boom in home ownership. And this is a major contributor to wealth inequalities between Black and white households. Even though it's no longer legal, we still see practices continuing. We see the predatory lending crisis of 2008 targeting Black and brown households and homeowners. We have well-documented ongoing discrimination in the rental market. So if you're going to rent an apartment today and you have the same sort of rental resume and you're a Black household versus a white household, you're much less likely to get that apartment. And therefore you are much more likely to spend more money for lower quality housing. You add to that the ongoing and well-documented discrimination in the criminal justice system and the employment system and educational discrimination. And just a reminder, we pay our public schools are funded large part by local taxes. These disinvested, formerly redlined neighborhoods have less money to put towards their public schools. It's perhaps not a surprise, but a deep, deep shame that Black Americans are at 3- to 4-fold increased risk of homelessness. In our beautiful city of San Francisco, we do even worse. Fewer than 5% of San Franciscans identify as Black, and 37% of those experiencing homelessness do. You may have heard and read in newspapers that the population of people experiencing homelessness is aging. And this is true. We were the first to document this phenomenon in a paper that came out in early 2006 that showed that among single homeless adults in San Francisco, the proportion of people who were 50 and older had increased dramatically. In the early 1990s, 11% of single homeless adults were 50 and older. By 2003, 37% were. When we look at the data now, approximately 50% of single adults who experience homelessness are age 50 and older. This, it turns out, is a generational effect. My colleague, Dennis Culhane, a professor at the University of Pennsylvania, showed that Americans born in the second half of the baby boom, approximately 1955 to 1965, have had an elevated risk of homelessness throughout their lifetime. This is a graph of the age distribution of male shelter users. In the US, he chose to look at men because he wanted to pull out moms and homeless families. And he found in the green line here in 1990 that there was this big spike of people who are aged 31 to 33. When he looked in 2000, there was this big spike of people aged 40 to 42. And when he looked in 2010, there was this big spike of people age 46 to 54. If you look back in time, what those people all have in common is that they were born in that second half of the baby boom. There are many reasons positive for this. This is a group of people that came of age in the second half of a baby boom. There is a sort of phenomenon that people in the second half of baby booms do less well in the labor markets because all the jobs have been taken by people in the first half of the baby boom. But this is also a group of people that entered adulthood during a recession. We know that people who enter adulthood and join the job market during a recession never make up the lost income. We know that this is a group of people who entered adulthood at a major change in our criminal justice policy. They basically entered adulthood in the era of mass incarceration, and this led to mass incarceration, particularly of Black and brown men in this age group. And finally, this is a group of people who entered adulthood in a very quiet but devastating change in federal policy on affordable housing. Right in the late 1970s and accelerating with Ronald Reagan in the early 1980s, there was a massive change in federal support for affordable housing. Since administrations have not restored those cuts, and we simply spend a lot less on affordable housing than we used to. That is the reason why homelessness has increased so much. This aging trend is expected to continue. Dr. Culhane and colleagues looked at those who are 65 and older experiencing homelessness, and their demographic projections say that this population will triple between 2017 and 2030, when the demographic community will change again and those numbers will drop. But until 2030, we're going to see this population accelerating. We were super interested in this phenomenon, and we were interested in many questions about how people became homeless in late life. Like, why were there so many people homeless in late life? Were these the same people who were homeless in their 20s and 30s and remained homeless, or is there something different going on? And really, what happens to them? Since 2013, we've had ongoing funding from the National Institute on Aging for a study that we call Hope Home, or the health outcomes of people experiencing homelessness in older middle age. It's a longitudinal cohort study in Oakland. We enrolled 350 participants between July 2013 and June 2014, and we've been following them every 6 months since. We got refunded and added an additional 100 participants in 2017, 2018. And then the next few weeks, we're going out into the field again for a second renewal, where we'll be recruiting another 200 participants to join those already there. To be in the study, you had to be 50 and older. You had to be English speaking. We are actually adding Spanish speakers in this age. That decision was made by our community advisory board, because when we started the study, there were very few Spanish speakers who were 50 and older and homeless. That population has now aged in to meet our study. And you had to be homeless when you were enrolled using the federal definition of homelessness, meaning you were either living outdoors in a place not meant for human habitation, you were staying in shelters, you had a quit order, you had to be evicted in the next 14 days and you had no place to go, or you were fleeing domestic violence. Once you got in the study, you stayed in the study, no matter whether you regained housing or not. And this has allowed us to really look more closely at this phenomenon. So let's go back to what we found. When we enrolled people, the median age was 57. Only 12% in that first cohort were 65 and older at enrollment. Consistent with other studies of homelessness, 3/4 of the population, or 77%, were men. 80% were Black American. This is in a city that at the time, about 26% of this population was Black. And everybody was very poor. 90% reported a household monthly income of less than $1,150 a month. This is in the Bay Area. So if you remember one thing from this talk, maybe remember this. We looked at that question of when did people first become homeless? And among those people, remember, everyone had to be 50 and older and homeless to be enrolled. We found that 44% had never been homeless, not even for one night, before they turned 50. You can see there was a group of people who, became homeless in their 40s, many in their late 40s. And we were really strict about this. If you had one night of homelessness in your 20s and then didn't become homeless until you're 57, we still considered you first homeless before 50. 44% had never, not even for a night, been homeless before the age of 50. So then we were interested, well, is there something different about these older adults who are homeless who first became 50 compared to those who became 50 later? And we found that those who first became homeless before 50 and remained homeless after the age of 50 reported many more severe adverse early childhood life experiences. This really sort of set them on a difficult path. They had low income attainment in early adulthood. They never married or partnered. They had an early onset of significant mental health problems, a lot of traumatic brain injury, much more likely to have had a lifetime history of imprisonment in state or federal prison than those first homeless after 50, and more likely to have an alcohol use problem. This was one of our participants. This participant we met when he was in his mid to late 50s, talking about the first time he became homeless when he was a young teen. He said, my father said, next time if you run away, I'll beat you with a car chain or I'm going to throw you out the window. Okay, so I wouldn't use the word reasonable. He's reflecting back to when he first became homeless. He was a teen, but I put things in perspective real quick. And I would say, could I survive a car chain? Probably not. Then I looked out the window and I said, we lived on the 13th floor. I said, I ain't playing with this man. He went to work. I had whatever I had on me and I was out the door. He became homeless that day. And his life since then really had been a series of being homeless or being in institutions and correctional facilities, in other sort of institutional settings, or being out in the streets. And we met him still out there in his late 50s. But how about those who had late onset homelessness? We found that their stories were very different. They had, in fact, worked throughout their lives, often more than one job, but generally physically demanding low-wage work. And then sometime after the age of 50, something happened. And that something sometimes was two things in combination, but it was always really one of these things. They either lost their job, their marriage broke up, they were sick, or their spouse or partner got sick, their spouse or partner died, or their parent died. We met many people who worked, difficult jobs and were living with mom. And when mom died in her late 70s, their name wasn't on the lease or they had no title to the house and they found themselves out on the street. We found that they had what we called a profound lack of advocacy. We saw many instances of evictions for reasons other than non-payment of rent, evictions that they should have been able to defend themselves against, but didn't have any defense against it. We found that they were not getting benefits to which they really were entitled. And every door they went looking for help, they just faced bureaucratic hurdles. They had low social support, not so much that they didn't have friends or family who loved them, but they had such deep shame about what was happening to them that they weren't really able to tell anyone or access any social support. And while they were much less likely to have been imprisoned or had a prolonged incarceration, they still reported that their housing and job opportunities throughout their lives had been hampered by a one-time charge, like a drug charge, when they were a young adult, or an unexplained arrest that they were never charged with, never convicted for, that hampered them throughout their lives and really foreclosed various opportunities. This was one of our participants. We found him living under a bridge in his 60s with his wife who was living with him, who was hemiparetic and blind, and they were under a bridge. It was a lot of different things, but the new owners took over. We were being evicted. My wife, she had just got out of the hospital, had the stroke and was blind. So the daughter came up and said, don't fight it. Y'all can come stay with me for a couple of months and save your money. So we said, okay. And we didn't fight the eviction. After we moved out of the place, turned in the keys and everything, we went over to her house, his wife's daughter's house, and she said, y'all can't stay here. Her boyfriend didn't want the elderly parent staying there. And I said, I got $9 in my pocket. I said, at least let your mother spend the night because we don't have enough money to get a motel room. She said no. So that was the beginning. They took all their worldly possessions. They toddled over to this bridge where we found them several months later. They stayed there for over a year until they eventually got housing, and the wife died soon after. While those with late onset homelessness tended to have fewer vulnerabilities, many had significant health challenges related to their homelessness. And in some ways, the easiest way to measure this is just asking people what we call the SF1 or the one item question. How would you rate your health? Poor, fair, good, very good, or excellent. This is known in general populations to have good predictive value of whether someone will die or wind up in the hospital. And we found in this population with a median age of 57 that 56% reported their health as fair or poor. We only see numbers like this in the general population for people in their oldest age, 80s and above. We found that self-reported chronic diseases were common, although we anticipate that they may have been underreported because folks had such poor access to care. But just looking at this, over half knew that they had a diagnosis of hypertension. 45% arthritis, 19% asthma. You can see that 6% at enrollment had already had a major cancer diagnosis. We didn't include non-melanoma skin cancers. And you can see that 7% had a diagnosis of congestive heart failure, 7% had had a heart attack already, and 11% had already had a stroke. We did a bunch of functional and cognitive testing, and we found that homeless older adults had high prevalence of both cognitive and functional impairment. In fact, using tests like the 3MS, we found that 25% met criteria for having cognitive impairment, and nearly 40% reported one or more impairments in activity of daily living, the majority of whom had two or more. Reminder that these are indicators. These are often things that tell us that someone might meet criteria or require nursing home care. And more than half reported at least one instrumental activity of daily living impairment. Again, median age 57. No matter what we looked at, these folks had many of the geriatric conditions that we usually associate with much older populations. 27% had a mobility impairment, 45% had a visual impairment, 36% had a hearing impairment, even though we actually had to exclude 4 potential participants who were profoundly deaf and we couldn't include in the study. Almost half had urinary incontinence. Now imagine trying to go out and finding new housing or a job if you have no place to launder your clothes and you have urinary incontinence. This leads me to say that when we're talking about homelessness, 50 is the new 75. The median age of our sample was 57, but we found a prevalence of geriatric conditions worse than those in general populations in their 70s and 80s. How about substance use? Yeah, substance use was common. About 65% had moderate or severe substance use symptoms based on the assist. 43% were cocaine, 13% opioids, 8% amphetamines, and 26% had either moderate or severe alcohol use symptoms based on the audit. 15% of those had severe symptomatology. Mental health problems were common as well. The predominant mental health problem was actually depression. We had over a third with moderate to severe depressive symptoms. We had about a third who met criteria for possible PTSD. Almost 20% had had at least one psychiatric hospitalization in their life, and about 5% had had a hospitalization for psychiatric reasons in the past 6 months. We found relatively high rates of healthcare utilization. Like, the good news was 72% of our sample said that they had a regular place for care that was not the emergency department. And actually 53% were able to give us a name of their primary care provider. Despite that, rates of emergency department use were astronomical. Half of all of our participants had visited the ED, and we only counted it if we could find the records. So it's probably an undercount, but half had visited an ED in the prior 6 months. It was, however, fewer than 7% who accounted for half of all the visits. There was a small group who used the ED repetitively. We have had absolutely devastating rates of mortality in this study. Remember, 350 people enrolled 2013 to 2014, 100 in 2017 to 2018, and we've had 131 confirmed deaths out of those 450 people. Actually, we learned of another one yesterday, so it's likely 132. This represents 29% of our cohort. The median age of death was 65, remembering that you couldn't enter the cohort unless you were already 50. We compared these rates to those in Oaklanders, and we adjusted for age and for gender. We found that the men in our study had over a 3-fold increased risk of death compared to men in Oakland, and women had a 5.2-fold increased risk of death compared to women of the same age in Oakland. The leading causes of death were heart disease and cancer, although drug overdoses were not that far behind. Throughout the SARS pandemic, the COVID pandemic, we have had 3 deaths directly attributable to COVID. However, we have seen what looks like a dramatic acceleration in the death rate since the pandemic began, even if those deaths were not directly attributable to SARS-CoV. So then we looked at what was associated with dying. Because we have longitudinal data, we're able to look at what increases your risk of death. Do you remember how I said that 44% had never been homeless until after they were 50, and that they were much less likely to have sort of substance use and mental health problems than those first homeless after 50? Despite that, those first episode of homeless after 50 was associated with a dramatic increased risk of death compared to those who had first been homeless before 50 in adjusted models with a 1.6 hazard ratio. Remaining homeless as compared to regaining your housing at some point during the study was associated with also a dramatic increased hazards of death. Those who remained housed had lower risk of death, or those who became housed had lower risk of death compared to those who remained homeless. Staying in a skilled nursing facility was associated with an increased risk of death. This is probably a fact cause. These folks have really no place to go if they're dying, and so often get sent to SNFs to die. Diabetes was associated with an increased hazard of death, and that single item question of how would you rate your health? If you said your health was fair or poor at one visit, you were significantly more likely to die than others were. So how about housing outcomes? So this really depends whether you're an optimist or a pessimist. 80% of our participants regained their housing at some point during the follow-up period. And you can see that a lot of that happened in the first year and a half. What was associated with regaining housing? If you had a case manager in the 6 months before, that could be because if you qualified for housing, you got a case manager, to help you find it, but it did seem like case management certainly helped. If you had an activities of daily living impairment, you are more likely. That's because we prioritize people in our homeless system for help based on things like the number of years that you've been homeless, or if you are sick. So that's probably what this represents. It could be that family members were more likely to take someone in when they were impaired. What made it less likely that you regain housing? An incident episode of incarceration. We found that 25% of our participants were incarcerated in the first 4 years after we started the study. If you had an episode of incarceration, even for a night, much less likely you were going to become housed. If you experienced sexual or physical abuse in the prior 6 months, less likely to regain housing. And those who were unsheltered compared to those who were in homeless shelters were also less likely to regain housing. So here's the bad news. If the good news was that 80% of people regained housing no longer met federal criteria for being homeless at a certain point, over half of those who regained their housing lost it again. And it took about 1.5 years after they regained housing until they fell back into homelessness. Oops. So what is associated with losing your housing? Once again, incarceration pops up. If you had an episode of incarceration, you were much more likely to fall back into homelessness. If you were housed and were incarcerated, you went back to homelessness. If you were an amphetamine user, it looks like you are more likely. These don't quite meet statistical significance, but those point estimates are quite far above 1. What was protective? What kept you housed after we adjusted for everything else? It was about whether you had support for your rent. Receiving a rental subsidy, such as in the form of a housing choice voucher, or if you were placed in public housing, or if you were entered into something called permanent supportive housing, which is subsidized housing with supportive services, you were much more likely to retain your housing. This story, at the end of the day, is all about your ability to pay the rent. So what do we do? The first thing that we have to do to get us out of this mess is to expand our availability of extremely low-income housing. Remember, extremely low-income housing is that's affordable for those who make less than 30% of the area median income. I want to refer you to this fantastic resource, the National Low-Income Housing Coalition, great advocacy organization, great data. They publish this report every year. This is the 2022 report showing that in our state of California, there are 1.3 million households who are extremely low income, and we are short 1 million units of housing that is affordable for that group. 1 million units. That's what we need to solve to get us out of this mess. So what is it going to take To increase our supply of ELI housing, it's going to take government action. It's going to take government action. And I'm just trying to lay out, this is like really quick and dirty, but like who's responsible for what? The biggest actors we need to get involved is we need action at the federal level. They have the ability to expand access to housing choice vouchers. Right now, only 1 in 4 households that qualify for rental subsidy receive them. Can you imagine with Medicaid, if we said, oh, you meet all the criteria for Medicaid, but sorry, we gave out all our Medicaid yesterday, so you don't have it. That's how housing choice vouchers work. In places like the Bay Area, the wait list to get your name on a wait list to get them have barely been open at all in the last 10 years. They open them for about a month every few years that you can stick your name on a list. The wait list to get these vouchers are years. It can be hard to use them if you get them. Landlords discriminate, there's not housing available, all of those things, but you can't even get a voucher. The federal government can also really hypercharge subsidies for affordable housing construction. It costs money to build housing. It costs a lot of money. The market cannot solve this. At the state level, the state can really put forth more funding for housing construction. They can enforce zoning regulations. They can do a lot, but they have to balance their budget every year. It's really the feds who can solve this problem with it, if they decided to. At the local level, I'll point out that mayors always get blamed for this problem, but in some ways they have the least that they can do to solve it, but they can do one thing that's really important that they do, which is reform zoning. Local government generally controls zoning. California, the hardest state in the country to build housing in, zoning reform, allowing more building, allowing building of low-income housing, allowing more construction, all of that will help. Inclusionary zoning, making builders who build, set aside a certain number of units for low-income renters as the price of getting building, all of these things can help. That's something that's under local control. So what else can we do? It's vitally important that we adhere to the evidence. We at UCSF believe in the evidence, right? There is a very clear evidence-based way to end homelessness, and that's through something that has been maligned a lot recently. There's a lot of rumors about it. Let me tell you, there is an extensive evidence base for Housing First. What is Housing First? It is not a specific program, and it's definitely not housing only. It's not that you get the housing, but you don't get any services. It's an evidence-based approach that prioritizes safe, permanent, affordable housing as a foundation. It basically says that if someone is homeless, you solve it by giving them housing, and you do not require as a precondition that they get treated for mental health problems, substance problems, or whatever else people want them treated for as a prerequisite. You start with the housing as the base, and then as needed, you make the services easily available, low barrier, but you don't require that people use them. This has been studied empirically. We've studied it empirically. It has an extremely high success rate, but you cannot require that people go through treatment in order to earn the right to housing. When people are homeless, that is the last thing on their minds. You need to start with the housing and build from there. How about those patients you've probably seen who have significant behavioral health disabilities, substance use, mental health challenges? You must say, oh, you can't just stick them in housing. You can, you must, it works. There's a model you might have heard of called permanent supportive housing that is based on a housing first philosophy. You don't require the services as a precondition. It's subsidized housing with linked voluntary supportive services. This has been shown to get people housed. It's been shown to keep people housed. Maria Raven and I published a study in Health Services Research a couple of years ago that was a randomized controlled trial in Santa Clara of the most impaired people in the county of Santa Clara. We found over time when we published it, 86% got housed and stayed housed. By the time the study ended 7 years later, 91% of the most impaired, the most difficult folks got housed. Once they were housed, they stayed housed for over 90% on average of their nights over the next 7 years. It works. It's what we have to do. Not all of these elders will need sort of permanent supportive housing, but most will need some form of subsidy. These folks are very, very poor. They cannot compete in our brutal housing market. Many will need something called housing navigation, where they get help identifying a renter, identifying an owner who is willing to rent to them, help with all of those things. Luckily now with CalAIM, the new Medicaid waiver, we can actually pay for services like housing navigation, first and last month's rent through this process, through Medicaid. We need more housing choice vouchers, and we need to be really creative here. Is there an opportunity for shared housing to decrease costs where people get to choose their roommates? Can we further support families so that they can take people in and eliminate their barriers to take their own loved ones in? Lots of work to be done. Some people are going to need more services. We have had a huge loss of things called residential care facilities, what we call board and care in California. We have many seniors with dementia, with other problems who are going to need the help that they can get in a board and care. We need to revitalize that industry and make it available to people. Some people will need assisted living. And some people will need PSH with a higher level of supportive services than we generally offer. We need to do that to solve this problem. So what can you do as a healthcare provider? The first thing that I'm going to ask you is to push back against the individual narrative. There is no amount of substance use treatment or mental health treatment or blaming the individual that's going to get us out of this mess if we don't solve the structural issues that got us here. Say, I'm an internist. I know how to treat mental health and substance use problems. I'm not afraid of those. Acknowledge that many people live with these problems and most of them are housed. There's nothing about having a mental health problem or a substance use problem that says you can't be housed. Speak out again about the connection between homelessness and health. The housing community, the affordable housing community is really pleading with us as healthcare providers to stand up and make our voices heard. People listen to us, tell stories about how awful it is for our patients' health to be homeless, and advocate for real evidence-based solutions. Homelessness in this country is reaching crisis proportion. The underlying causes are structural, and the aging of this population increases the urgency for us to act. The suffering we see out there is immeasurable. The use of the healthcare system can be really chaotic for people who are homeless, but the solution to homelessness is housing. And I'm going to just sort of have a call to action here for you to become involved in solving this problem. And join me in my tagline, there is no medicine as powerful as housing. Thanks so much, and I'm happy to take questions.
Thank you, Margot. Go ahead and take down the slides if you can.
Yes.
And plenty of time, so that's great. Let me start at the end and work backwards. Can you talk a little bit for those people that are inspired by you about an academic career focused on evidence, but also advocacy, and how do you get that balance right?
Yeah, sure. I think, there is a need for people in all sorts of spaces, right? And I would say I am an advocate, but I'm actually a researcher first. And I would distinguish those saying, I advocate strongly for the end of homelessness. I'll come clean about that. I think it's atrocious, but I don't actually have like a horse in the race or whatever that analogy is of how we do it, right? And so we have all of these skills that we've gained, through like learning how to do research and stuff, that I sort of come at it as my role is to try to help sort through the mess of evidence and develop evidence where the evidence isn't there. And I work closely with advocacy partners. So I'm in communication with them. They might say, hey, do you have anything on this? Or what's your advice on this? And I'll give them advice. And I do advocate in the sense that I speak out in many places, but I know my place in this role, and that is, I'm funded mostly by the NIH. I mean, I've gotten a lot of foundation funding. Recently, I was really blessed with the funding from the Benioff Foundation family, which has been incredibly important. But I have a lot of funding from the NIH because at the end of the day, I'm looking at like what the evidence says and trying to generate that. But I spend a lot of my time talking to media, often on background. I've done, I think, 2 or 3 conversations this morning. I talk probably to 10 media people a day, often on background, trying to help them understand the problem, trying to help their stories reflect the truth. I spend a lot of time at the Capitol, giving legislative briefings and things to try to help our policymakers get to it. I will say that there is a real hunger for this. I think it can be uncomfortable. Sometimes you find something that you wish you didn't find. And I say, my credibility is worth more than anything else. At the end of the day, like I kind of call it like I see it.
Great. That's a dicey follow-up, but can you give an example of something you found that you had to come clean with?
Yeah, I think the most painful example was actually one of the first studies I did. So it was even harder because I was really young and I didn't really, I hadn't been in this a long time. But I think I believed when permanent supportive housing. So just to become clear, people are always like, why doesn't San Francisco do what Utah did? Like Utah literally followed San Francisco's model, or Houston is all in the reach now that Houston's doing a great job with permanent supportive housing and housing first. They're following, housing first sort of started with in New York, the Sampson Barris, but San Francisco is a really early adopter. And we started doing permanent supportive housing on a wide scale in the late 1990s. I worked with the health department, got a bunch of data, and basically did one of the very first evaluations of permanent supportive housing. And I will admit to you that I believe that if we put people in permanent supportive housing, they would use healthcare, right? And we would save money on healthcare. And you still hear that a lot, like, oh, it's going to save money on healthcare. But that, in retrospect, of course, this population overuses some form of care, but they actually underuse a lot of other forms of care, right? And so what we did is we did a really good study. We had a control group, like a waitlist control. And when we first look at the data, the use of acute healthcare went way down. And when I looked at the control group, it was superimposed. It was the same. It went down the same amount. Now, in our study in Santa Clara, we did see differences, let's say in psychiatric emergency room use. That makes sense as internists, right? If you've got advanced heart failure, you still are going to have exacerbations where psychiatric care might be a little more amenable to this. But what we found was that those curves were superimposed, and there were people who were really angry at me, really angry. I had phone calls from people saying, don't put this out. You're going to hurt people. You're going to ruin our narrative. And Andy Beinman was, my division chief then. And I was actually in tears, and I called him. I was like, I don't know what to do. I don't mean to hurt people, but this is what we found. And he was like, Margot, you're in this for the long game. You have to call it like it is, but also help people understand what could be going on, reframe the question. And, we put that out. It was painful, but I think I sort of reframed the question. We used it to try to help, could we do services better so that we could actually meet the need? But I also realized, I actually had some patients who were in the study, and they would have a nurse at their site who would call me and say, Mr. So-and-so's blood pressure is 210/110 and his chest hurts. Well, call an ambulance, he's having a heart attack, like that. So that counted as an emergency department visit. Is that the right indicator of use, right? And so that was a painful experience. Years later, a group of us co-wrote a perspective for New England Journal, and we actually co-wrote it with a big group because none of us were brave enough to have our only ones be the name on it, saying, why does everyone keep saying it saves money in healthcare? This population is really medically underserved in many ways, and that's the wrong metric. Nothing we do in healthcare, maybe vaccines do, but very little we do save healthcare dollars. We want healthcare dollars to be well used, right? We talk about quality of life, and we talk about, is it a reasonable expense for the value? But why isn't, when we're talking about desperately poor people, often people of color, do we want to pull money out of the system? That's actually not the goal. The goal is they got housed, they stayed housed, and their life improved. We didn't save money on healthcare. That was an example.
Yeah, no, that's a great. So one of the questions came in, how much would it cost to, quote, solve housing in California? But let me extend that and connect it to what you just said. When people hear about a big government expenditure, they also want to hear, what is the return on investment?
Yeah.
And so you've just said it's not in healthcare.
Yeah.
Is there anything in terms of housing values or
Yeah.
quality of life? Obviously, the moral argument is profound, but if you're a government, is there some return that you get from doing this well, and what is it?
Absolutely. I mean, so just looking so in California, let's say only a third of people experience homelessness or sheltered. Most people are unsheltered. So across the country, about 50% of people experiencing homelessness are in shelters. So not even 100%. The federal spend, if you add up all the money that we spend on homeless shelters, you could almost close that gap of housing choice vouchers, like what it would cost to give everybody a housing choice voucher from that money. You know, the amount of money we spend on cleaning, the amount of money that costs public works, and the amount of policing we spend to not solve the problem, right? There are lots of ways. And then when you talk to business leaders, I spend a lot of time talking to business leaders, to leaders in the tourism industry. They point to homelessness as like really destructive, not to mention, people say that it's their number one problem. Like, it is not good for any of us. When we are all housed, we're going to thrive as a community. It's really interesting, Bob. You and I don't talk about it a lot, but we both live in subsidized housing. Like, you own your house, I own my house. If you own your house, you get this huge federal subsidy because you don't pay taxes on the interest, right? You have like mortgage interest tax deduction. That was a decision, a policy decision, with the idea that like home ownership is good, it stabilizes society, right? I would say, first of all, in what universe are you and I subsidized and my patients are not, right? But it turns out subsidizing people's housing is a good thing because it stabilizes society. So there are lots of return on investment. It just might not come through the health system quite yet. I think it actually will, by the way, if we house people earlier, but like end stage permanent supportive housing, probably not.
Makes sense. Let me guess that many of your media calls in the last few days were around New York City's new policy to essentially round up some homeless people and take them to the hospital for psychiatric evaluation. Right. Assume that you don't think that's a great idea, but can you describe kind of what your take on that is?
Yeah, I mean, first of all, I think, having police in charge of this is always going to be a bad idea. Secondly, if you talk to like my colleague Maria Raven, close colleague, runs the ED at Parnassus, they're filled with people needing psychiatric evaluation, and she can't get them that evaluation. She can't get them a bed, even if they needed it. We have to be honest that we're not serving the people we have who need it. And so when I talk to my ED colleagues, like Kelly Duran, who's a homelessness researcher and ED doc at Bellevue, she's like, what? Like, what are we gonna do? You're gonna disrupt these people. You're gonna frighten them. You're gonna like totally, and then like, what are we gonna do? There's no housing. Like, there's no housing. Like, what, even if they get admitted to a psychiatric hospital, if they get admitted for, what are they going to be admitted for? Like a week, 2 weeks, and then they go out back to the street, it's going to happen again. It's not the solution. It's sort of a political window dressing, but it's going to be really harmful.
Got it. Sujatha asked, zooming from the larger view to the individual patient who a clinician is taking care of, hospital, clinic, and there is no housing available.
Yeah.
What should clinicians know? What should they do in the care of these folks?
Yeah, I mean, so I think the first thing is to know the community resources. Our resources are overwhelmed, but we do have resources. We have a respite center. It's always full, but you can sometimes advocate to get your patient in, which is a medically supervised sort of shelter where people can go when they're leaving the hospital, or once in a while if they're going, would otherwise need to be in the hospital, you can argue for them. Our shelter system has shelter health. So if, let's say, you're discharging someone, you can advocate, you can work with the social work team to try to get them a shelter bed, explain that there's a medical need, and they and then communicate with the shelter health teams, who can send a nurse practitioner, a physician around to help with that. You can advocate that people need to spend the day there. So really sort of help the system understand who's most at need. We need to make sure that our patients are entered into something called coordinated entry. Coordinated entry is a HUD mandated system that every part of the country has to have, that basically is a system of prioritizing people for services. Because of Proposition C, San Francisco has a lot more new money flowing into this. There's going to be a lot of housing units brought online, a lot of services brought online, but they need to know who's in it. And so that is a phone call. A lot of it is being done over the phone. You can look it up, Coordinated Entry San Francisco. There are like, call this number. It can be hard for patients. They have to go through a system of relatively invasive questions, but it's basically creating a line list of who is homeless and what problems they have, so that as these new resources come on board, which many will, they can get them. I would say recognize your patient's humanity. Like, as a primary care provider, I can tell when people are becoming homeless because suddenly like their well-controlled diabetes and hypertension gets out of control. And so I ask all of my patients, I say to all of my patients, and I normalize it. How I ask is, homelessness is a mess in San Francisco. It's really expensive. How's it going for you? And then they'll tell you, we have screening questions in both the General's EPIC, the VA has it, and UCSF Health has it in the housing portion that I encourage people to ask and to fill out. If someone says, I'm housed, I ask, are you worried you're going to lose it? I promise you a huge proportion of your patients, certainly at the General and any, here, is worried about that. We can get them legal help. We can get them some homeless prevention services sometimes, but we can't do it if we don't know it. Also, simplify regimens. Don't give people really complicated regimens. You're not going for tight control when someone's living outside. Think about what barriers they're facing. Make things as easy as possible for them. You can get SF Hot, you can get outreach services for them. So there's like a lot of resources in San Francisco, but they need our partnership to know.
I guess an analog to the question about, okay, they get psychiatric care if you can get it, but it's only for a short period of time.
Yeah.
You send them to a shelter, for how long? Is that just temporizing? What happens?
Yeah, I mean, it's not great. I mean, in San Francisco, there's all this scuttlebutt in the media. You'd think like all these people are refusing shelter. There's like thousands of people on wait lists for shelter, right? One of the things I think we can do as healthcare providers is help prioritize. There are ways that if someone is like really dying out there in the street, they're going to try to get them into care sooner. So you can help prioritize, but it's brutal out there. There are things called navigation centers, which are sort of souped up shelters. They have more services and things. It used to be that you went there and stayed until you were housed. Now they're time limited. So the truth is that people are going to be thrown back onto the street. We need to temporize as best we can. Like, because we can't solve the problem doesn't mean we let people die out there, but we are letting people die out there. We have to do the best we can. But there's so much room, Bob, for healthcare providers to be like, whenever you take that small action, take the big action too. We really need to help explain to the public what this problem is and how we're going to get out of it. And we have to just temporize the best we can. I mean, there are a lot of great people working to try to make people's lives better when they're out there.
When you describe, maybe a couple more questions, when you describe the health problems, cause, effect, what's the sort of pathophysiology? What starts first?
Yeah, I think it's a both and here, right? We know that clearly mental health and substance use disorders, right? Those mess up your lives and make it harder to compete in a brutal sort of rental market. Not surprising, you're at higher risk. But we have a lot of good evidence that, and we just finished this big statewide study of homelessness, results to come out end of March. It's really sort of astonishing. People report they use more after they become homeless. They use it as a coping mechanism. They use it, they have little less ability to stop it. So I think it's both.
Maybe not so much talking about substance use and mental problems. I'm talking about
chronic disease. Right. So chronic disease and things gets much worse when you become homeless because people can't adhere to, think of everything we do for someone, let's say with diabetes or heart disease. It's like bizarro world, right? We're telling people, take your medicines every day and don't miss them. Well, medicines get taken in these sweeps. People can't get to the pharmacy and it's hard enough to work with insurance as it is, right? They can't remember to take their medicine. The medicines get lost, stolen, they get rained on, so can't take their medicines. Diet goes to heck. Sleep is really underappreciated, but folks who are homeless do not sleep. They sleep in like short, increments. So all of that fits together to dramatically worsen chronic disease control. And the other thing is it's harder to get care sort of as you need it, right? People might have a diabetes related infection that they can't get in to see us soon enough. So yes, there's a lot of, cause effect, but there's a direct causal mechanism. And, in our mortality study, I was actually not sure we were going to see that housing decreased it because people who are really sick get prioritized for housing. So I thought that might take away any ability for us to see a mortality benefit. We saw a really clear mortality benefit for getting housed. And I think that speaks to the ability to manage chronic diseases and other things like that.
Maybe last question. I've always gotten the sense from you that despite working in what feels like a pretty depressing area, you're pretty optimistic. And is that just you or you can-do person? Or are you actually optimistic that we're making some headway here?
I'm an optimistic person. I mean, hope is a discipline. I keep saying that. I say that to my team every day. It's like from Miriam Kaba, this abolitionist, where it's like, hope is a discipline. You got to have hope. Otherwise, where are you going? I actually am not that optimistic, to be honest, because what I see is we are in a period of just backlash. I get reamed on Twitter by like, I'm a liberal, and there's, people who are pretty. There are some people who are pretty bad actors who are out there actually trying to sort of stir the pot and turn us back into sort of more policing, more criminalization. And then I think the public maybe just doesn't fully understand what's going on. It seems confusing what's going on. The thing that makes me worried is that the only people who can solve this are Congress, and it's going to be hard, it's hard to get things passed. On the other hand, if Congress overnight decided to fully fund the housing choice voucher system, something that they could do overnight, still not help that much in California because we literally don't have the housing to use it in. But in most of the country, family homelessness disappear overnight. Homelessness rates go way down, and it would provide an ongoing support for affordable housing. The Newsom administration correctly says California cannot do ongoing vouchers because California needs to balance their budget every year. This has to be a federal responsibility. And so they are starting to talk about it. Like Build Back Better had some voucher increases in it. It got cut before it got passed, but that's what we're going to need. So we need to actually realize that there's an organized sort of very wedge issue political counterforce that we need to be sure to have our voices be louder. So I'm an optimistic person because hope is a discipline, but we're in a tough spot.
Understood. Well, thank you for all the amazing work you're doing to try to make it better and to inspire all the rest of us, and really, really appreciate it. And thanks for speaking today.
Thanks for having me.
Stay safe, and we'll see you next week.